Welcome to the fourth part of our increased work of breathing series. This session we're going to be looking at the signs and symptoms of increased work of breathing.
The aim of this session is to discuss the signs and symptoms of increased work of breathing in terms of vital signs of blood results, observation, physiotherapy assessment, and increased work of breathing in specific conditions.
So what are the signs of increased work of breathing? So you'll either gain this from the news chart or your own assessment if you've taken in an OBS machine. You'll gain some of it from the notes. The most obvious sign of an increased work of breathing will be an increase to the respiratory rate. So generally anything more than 20 breaths per minute is a sign that your patient has increased work of breathing. If someone does have an increased work of breathing, you may also see that they've got a decreased SpO2, and that's decreased from what their normal is. And check the trends in the news chart and any notes in the medical notes to indicate what their normal range is. So bear in mind that an SpO2 of 90 is not low for everybody, particularly those with chronic lung diseases like COPD. The patient may present with an altered heart rate, so they could be tachycardic or they could be bradycardic. So if someone's got, they could have a heart rate greater than 120, or it could be less. It could be less than 50. If they're bradycardic, it tends to be an indication that they're in severe respiratory distress or failure. The patient may have deranged ABGs. So if the patient's had a set of ABGs, they could either be in respiratory alkalosis or metabolic acidosis. So if they're in respiratory alkalosis, it's due to the excess alveolar ventilation, so they've been hyperventilating. So if someone's hyperventilating, they're going to blow off more carbon dioxide than they would normally. This causes the partial pressure of carbon dioxide to be reduced and increases the alkalosis. Another reason a patient may be showing signs of increased work of breathing could be because of a metabolic disorder. The patient may have metabolic acidosis, and the patient would be compensating for the increase in the bicarbonate within their blood, and they'll do that by blowing off excess carbon dioxide. Another thing that you may note on the ABGs is the patient may be in respiratory failure. So respiratory failure occurs when the gas exchange in the lungs is significantly impairs and it causes a drop in the oxygen levels within the blood, so causing the patient to be hypoxic. This can occur with or without changes in the carbon dioxide.
On observation, there are some things that you may see. Remember, this won't be in every patient. You may see an altered breathing pattern. The patient may breathe deeper as they're trying to get more air in, so breathing deeper in. But they may also not, they may breathe shallower, particularly if they've got a particularly high respiratory rate. So therefore, they're just trying to get as much air in as possible and they're not able to take a deep breath. So it would be, as you can see, I'm not able to take a breath in to the bottom of my lungs. The patient may do something called pursed lip breathing. You'll see abbreviated as PLB, which looks like this. Some patients may have been taught this, but a lot of patients will do this automatically. It's something that they do to try and compensate. The theory with pursed lip breathing is what they're doing is breathing out against the pursed lip creates pressure within the airway, and this helps to splint the airways open. This makes it then easier for the air to flow in and out, as it's splinting the airways open so the cartilage isn't collapsing down, and it makes it easier to flow. You may also see patients mouth breathe as if they're trying to get more air into their lungs. So all of these are a sign that your patient may have some increased work of breathing. The accessory muscles of respiration include sternocleidomastoid, your scalenes, trapezius, your internal intercostal muscles and your abdominal muscles. Due to dynamic hyperinflation at ear tramping and COPD, patients put the diaphragm and your intercostal muscles at a mechanical disadvantage. So because of this, if there's then any stress placed on their body, they're more likely to rely on their accessory muscles to help facilitate ventilation. So when we talk about someone displaying accessory muscle use, they may fix their shoulder girdle so that the sort of fixing it like this, and then they're going to work harder to breathe. So you can see here, you can see my sternocleidomastoid, you can see my trapezius here. Okay, so that's what it would look like. The next picture I'm going to show you demonstrates that a bit more clearly. The other thing to note in this photo is that the subclavicular fossa has recessed in. Okay, if you look back at the photo there. So this is due to the increased area resistance as part of the COPD disease process. So because of the increased area resistance, there's a delay between the generation of negative inspiratory pressure. So there's negative pressure within the lungs, and there's a delay in that equalising when there's a change in the lung volume. So because there's a change in the negative pressure, it's going to draw in at the subclavicular fossa, and you may also see this happen in the intercostal spaces as well. Another sign of increased work of breathing, which is particularly relevant for our patients with COPD, is something called the Hoover sign. So normally with inspiration, if you pop your hands on and take a breath in, you'll feel that there's an outward motion of the rib cage. Now, what can happen with these patients with chronic COPD is because they're so chronically hyperinflated, their diaphragm, rather than being nice, round and domed, becomes flat. And what that means is that rather than the outward motion, the rib cage will pull in, and that is commonly known as the Hoover sign. Nasal flaring is something which can happen in paediatrics and is a sign that the infant is in respiratory distress. The infant will flare their nostrils in order to just try and get more air in. You don't tend to see this in adults, but it is a sign of distress in children. So as I said at the start, you're not going to see all of these signs with every patient who's got increased work of breathing. What I have done is to highlight in bold the two which are most common. So you're more likely to see an altered breathing pattern and use of accessory muscles. Don't forget that work of breathing can be something which is acute or something that's chronic. So a patient who's had surgery, for example, and is struggling due to pain, fatigue, and the effects of analgesia, that could be someone who's normally fit and well. They're not going to display any of the other things. That's an acute problem. Whereas somebody who's got COPD may display some of the other ones, but not everyone with COPD is going to have the Hoover sign or show the intercostal or subclavicular recession. It's just something that if you see it, that's what's happening.
So what might we find on our physiotherapy assessment? Taking palpation first, there may be an altered thoracic expansion. Thoracic expansion may be increased when the patient's normal, so the patient's gasping to get air in, they may be taking a deeper breath, therefore you may feel increased movement from what you would normally expect. However, it could be that it's decreased because if you think if you're really short of breath and taking lots of smaller breaths, if you've got a respiratory rate in the 20s or into the 30s, you're not going to be able to get significant air into the lungs in order to generate a decent thoracic expansion. With auscultation, air entry may be altered. So it could be decreased at the bases for the same reason that on palpation you feel it's decreased. So the patient may not be able to get enough air into their lungs for you to be able to hear anything. This could also be positional. So if your patient's slumped in bed or if they're using their accessory muscles, they're not in an advantageous position for ventilation. So there might not be enough air in. It could be that your patient has asymmetrical breath sounds depending on the pathology. So the right may be different to the left, and it's always important to know if it's the same. Depending again on the pathology, there may be an expiratory wheeze if the cause of the breathlessness is caused particularly by bronchospasm. The cough may also be altered, and this may be due to the fact that they've got, if they're short of breath, they won't be able to generate an adequate force to get a productive cough. So as you can see, there's no right or wrong. They can be increased and decreased with these physiotherapy skills. It's not a one size fits all for patients with increased work of breathing. So just take the patient's findings as a whole, and you'll be able to get a good idea of what the problems are. So let's have a look at what the characteristics of different types of dyspnea are. So we're going to look at some different pathologies and look at how it will present in a different manner for each of them. So we'll take COPD first. So if someone's got COPD, their breathlessness will come on slowly as the disease progresses. So someone with the early stages of disease might not have breathlessness or dyspnea unless they're doing something which overly exerts them. So, for example, carrying some shopping bags up 3 stories in their tenement flat. If someone's got COPD, they may also have a productive cough, and they may also suffer from fatigue. So one of the reasons that COPD breath is misdiagnosed is that people see their breathlessness as a simple part of getting older, and they don't report this symptom to the GP. If someone has an acute exacerbation of COPD, their breathlessness will be worse. This is due to increased airway resistance secondary to bronchospasm, increased sputum production, and inflammation within the airways. The increased airway resistance increases the load on the respiratory muscles and also increases the ventilatory drive, causing the patient to be more breathless. So with asthma, the breathlessness will be episodic, so it will just be in relation to the bronchospasm within their chest. So whatever's brought their asthma attack on, they may feel their chest tight, and because of the bronchospasm, they may also have the wheeze, which we mentioned earlier on. Pulmonary fibrosis is a type of interstitial lung disease. It is a disease where the alveoli accumulate more scar tissue. As a result, there's decreased oxygen absorbed into the blood. This is then picked up by the chemoreceptors, and then the brain increases the ventilatory demand. Shortness of breath is an early sign of pulmonary fibrosis, and this gets progressively worse as the disease progresses. Pneumothorax. So if someone's got a collapsed lung, it'll be a sudden onset, and it'll come with some severe pleuritic pain, and they'll have significant breathlessness. If somebody's got something called hyperventilation syndrome, that's a direct symptom of a decreased PCO2. So these patients will suffer with the air hunger, which was discussed in the physiology lecture, and it's not relieved by rest. Pulmonary edema means there's a collection of excess watery fluid within the lungs. The patient may feel that they are suffocating, and the breathlessness will alter depending on the position that they're in. On auscultation, you will hear bilateral fine crackles. People who are having a heart attack may also suffer with breathlessness. This will be a sudden onset of breathlessness associated with the crushing central pain that they report, and also nausea. If we think of our neuromuscular patients who are suffering with breathlessness, it tends to be exertional, so anything they're doing to increase the load on the respiratory muscles, and they may also have rapid shallow breathing. You would imagine they would also have a diagnosis of a neuromuscular disease. This is not an exhaustive list of disorders which can cause breathlessness. It's just a few examples of the kind of disorders that you may deal with as a physiotherapist in practice.
One final thing. So as you'll have noted, patients present in a variety of different manners. Therefore, it's very important to look at your picture of the patient as a whole to understand the cause of their increase of work of breathing, as this is going to influence your treatments. As you can see, it's not a one-size-fits-all approach, as our patients are all very different.